I'd like to welcome all the attendees here for joining us in today's webinar on Medicare Set Aside, Medicare Advantage, and Medicare prescription drugs, featuring Brian Bargander of Humana. My name is Sean Dean, and again, I'm General Counsel with Ametros. And the intersection with Medicare secondary payer and Medicare Advantage has been a really hot topic in the industry for some time now. In my opinion, no one's more versed in this area and an expert than our featured presenter today, Brian Bargander. So just a little bit of a background about Brian. He's an internal consultant at Humana, which is one of the country's largest Medicare Advantage organizations. And in recent years, Humana has been heavily involved in efforts to clarify and enforce the MSP rules that pertain to Medicare Advantage. Brian has 15 years plus of experience in leading and improving health benefit subrogation and MSP operations. And in this role at Humana, he devotes considerable attention to identifying and monitoring trends that could impact subrogation and MSP recovery efforts, and in developing new cost avoidance and recovery projects and advising operational leaders regarding subrogation and MSP issues. And we're very glad to have Brian with us today to discuss Medicare Advantage issues, the direction Advantage plans take with the Centers for Medicare and Medicaid Services, and how enforcement works and what data the Advantage and prescription drug plans receive, as well as a few other considerations. Again, my name's Sean, and I'm General Counsel with Ametros, and I'll be acting as host and moderator today. And a couple of housekeeping notes: attendees are going to be on mute during the webinar, and we'll aggregate any questions that come in, and we'll try to get to as many as we can towards the end of the presentation. And with that, I'm going to turn it over to the star of today's show, Brian. But before I do, and hopefully I'm not putting you on the spot, Brian, it'd be great if in your own words you could give us a little bit of a background, go into depth about how you became involved with this. Many of the attendees have probably heard you speak quite a bit before on this topic, but would love to hear about your background and your role at Humana and how you got where you're at today. Brian?
Well, thank you. Always happy to speak on this topic because I think a lot of people probably came to this in a way that's not dissimilar from the way that I got to it. And especially in the Medicare Advantage world, there's not a lot of information available directly from CMS, or what is information is available is scattered, and it takes a lot of time to put it together. My initial exposure to Medicare Advantage and Part D at Humana came when I was leading a team, and my team was tasked with setting up our original program for investigating referrals from CMS for Part D. So if you think way back more than 10 years ago, when the Part D program was set up, each plan that was involved in Part D was eventually tasked with investigating to make sure that the plan was not paying for prescription drugs that another payer should have been paying for. But there was, other than we need to do this, there really wasn't a lot of direction. Some of you, or many of the people in the audience, as you said, have heard me speak before. I'm not an attorney. My background is in economic development and workers' comp and unemployment comp in a previous life, working for the Wisconsin Department of Workforce Development. And I assumed there would be an attorney around who could tell me what to do. And at the time, there really wasn't. So I had to build my knowledge by being self-taught. And so I'm happy to share what I've learned over the years with anybody else who's willing to listen. And we do a lot of these presentations because we are trying to make clear what it is that we're actually trying to accomplish, and hopefully get cooperation from the primary payers in the industry as well, or other parties that are in a position to help us out. So we'd like to explain what we're told to do by CMS and some of the barriers we're dealing with, in the hopes that we can get some cooperation so we can all make the secondary payer process work a little bit better. So with that in mind, here's what we'll cover today. For those who aren't already familiar, we're going to talk a little bit about Medicare Advantage and the prescription drug program, along with some of the background and why we do what we do. The direction that we get from CMS with respect to Medicare secondary payer, and a little more emphasis on Medicare set-asides today. then something that I haven't spent a lot of time in previous presentations, and a lot of this is relatively new material on the enforcement data that CMS shares with us and how we put that to use, and also talking about how we're doing Medicare secondary payer enforcement and how we see others in the Medicare Advantage space doing that as well. And then we'll talk about a few other considerations toward the end, and maybe some new trends as well. So let's jump in with our first slides. So as a refresher, the Medicare statutes are built in 5 parts. You have original Medicare under Parts A and B, the physician and professional services portions of Medicare. Medicare Advantage is a separate part of the Medicare statute. That's a program for private administration of Medicare benefits under contract to CMS. And then you have the Part D program, which is prescription drug, which is an add-on benefit that can be acquired by somebody who carries both Part A and B through original Medicare, or somebody who opts to get their Medicare benefits through Part C. And then the final part of the statute is the Medicare secondary payer rules, which are written to encompass and apply to all 4 other parts of the Medicare statute. Let's move on. So again, a brief overview. Part C, Medicare Advantage or MA, replaces Parts A and B. The expectation from CMS is we follow the same claim payment guidelines that they would have contractors do for Parts A and B. There are some additional rules that are set up in terms of protections for beneficiaries. And we're also allowed to do some things that CMS can't do with original Medicare. And there's some, in particular, some special benefits we're authorized to provide. Unlike a contract for Parts A and B, where you may have a claim contractor that handles Part A claims and B claims, you have a separate contractor that does Medicare secondary payer enforcement against no-fault and work comp settlements or claims, or a coordination of benefits contractor that does the coordination with group health or liability settlements. All of those functions under Parts A and B or under CMS are self-contained within the Medicare Advantage plan as part of our contract, in addition to enrollment and things like that. Next slide. The Part D program is, again, a standalone coverage that's really optional for most beneficiaries, except for Medicaid individuals. So if you have a person who has dual coverage with Medicare and Medicaid, they automatically will either be enrolled or assigned to a Part D plan. And much like Medicare Advantage, these are also plans that are administered under a contract with CMS. They can be standalone coverage, so you may have somebody who has benefits under Parts A and B, but also has a Part D plan. You could see coverage bundled in with a Medicare Advantage plan, and in some cases you could see a Medicare Advantage plan and a separate Part D plan. More often that's most likely to happen where the Medicare Advantage plan is very small and for whatever reason does not have the wherewithal to run a Part D plan as well. But it's not that common. Let's move on to the next slide. Right now, 40% of 40% of the Medicare population, whether they are working past retirement or if they are qualified because of end-stage renal disease or disability prior to age 65, 40% of that total population is in a Medicare Advantage plan of some kind. Those numbers vary very widely by state. You'll have states like Florida and Minnesota where the percentages are rapidly approaching 50%. You have other states such as Wyoming where it's probably much less than 10. It's really a function of the way the Part C plans operate, which is to try to control costs by getting individuals into networks with participating physicians. In parts of the country where it's easy to get physicians to sign into a network and get enough physicians to make a viable network that's going to be attractive to beneficiaries, you will see more Medicare Advantage activity. In parts of the country where it's harder to get physicians to participate, Medicare Advantage may be offered, but it's probably not going to be as have as much market penetration. And then as far as the Part D plans, 75% of all Medicare beneficiaries have some form of Part D coverage. More often, it's going to be somebody who's got Part A and B, but also has that separate standalone Part D or prescription drug benefit coverage. But it's also a fairly significant share where it could be bundled in with a Medicare Advantage plan. And then one more number to think about. I've heard this at conferences and I've seen some of the research. I can confirm with data that we now have from CMS that more than 90% of Medicare beneficiaries who are in formally reviewed and approved Medicare Set Aside agreements self-administer those benefits for themselves, or self-administer that Set Aside agreement for themselves. And that's a lot of the reason for why I'm happy to do this presentation today, is because I think there's some room for improvement in how set-asides are looked at the time of settlement, and a need to get some information out there about some of the potential pitfalls of the way things get done right now.
And just to interject, Brian, I'll tell you, that stat from a professional administration perspective is absolutely accurate.
Yeah, I've heard other people say it, and when we had the opportunity to confirm it through the data that we get from CMS, and we'll talk about the data a little bit more later, but it was really kind of surprising and very difficult to believe that it would be that high, knowing what I know of MSAs. Now, I'm not involved in the administration. I attend conferences. I know how complicated they are to set up. Don't put me in front of somebody and ask me to set one up. I would run away. So when I hear that, when somebody tells me it's well over 90%, I'm really surprised at that, but the data that we get from CMS bears it out. And it's such a complicated area that, our concern would be, and seemingly CMS is going this way as well, that there probably are times when a set-aside is set up for self-administration where it might not be in the best interest of the Medicare beneficiary or the Medicare program. But anyway, at the end of the day, what we want, and really what you're going to see from most Medicare Advantage plans, is, as I said, we do full administration of the Medicare program under Part C in a self-contained environment where we're doing the claim payment, we're doing investigation for secondary payer, we're handling grievances and appeals and all of these other things, and a lot of functions that really have nothing to do with Medicare secondary payer. We want to operate these plans in order to justify our existence to CMS and to do this efficiently and be able to pay for what we're doing. We need to administer these plans with as little spillover for beneficiaries or the treatment providers that participate in our networks. And we don't want to disrupt all of the other things that we have to do in order to be compliant with what CMS expects outside of the Medicare secondary payer sphere. At the end of the day, though, we still have to demonstrate to CMS that we are being compliant with whatever rules they do spell out for us. And we're trying to, because this is a private enterprise, trying to be predictable and expedient and cost efficient in how we do what we are expected to do, and not just following the letter of what the law is on secondary repair, but also trying to match what the spirit of the rules are as well, which is ultimately to protect the Medicare trust fund. And you know, periodically you will hear this, not as often as I would think people would want to pay attention, but the Part A trust fund is going to expire in, or will be exhausted in about 7 years. I personally, in my role, don't get to talk to CMS very often, but that comes up almost every time I do get to talk to somebody at CMS, that trust fund, trust fund, trust fund, protect the trust fund, and that's what their focus is, very clearly. And we have to do our part under the Part C program to protect the trust fund as well. So what direction are we getting from CMS? So a refresher on the Medicare secondary payer direction in general. We are told that we have to enforce, excuse me, we have to enforce the same regulations for secondary payer that CMS tells its regular contractors, the CRC, the BCRC, et cetera. We have to follow those same regulations with respect to non-group health plan enforcement. The language CMS uses is interesting. It's not permissive. It doesn't say we have the option of doing this. It's always we will, or we are expected to, we will do this. We're also supposed to follow general guidance in the operational manuals published by CMS, such as the Medicare Secondary Payer Manual, the Claims Processing Manual, the Program Integrity Manual, and also some manuals that are specifically issued to Part C and D plans. We have to follow national coverage determinations. National coverage determinations is specified in the regulations, but it's not actually defined. For a long time, it was assumed that that was just the national coverage determinations that covered things like what's going to be the payment rate for durable medical equipment, or how do you prevent unbundling when you have like an orthopedic surgery and multiple charges related to that surgery. It's now understood as things that maybe are not directed directly at Part C and D plans and are not specific to claim payment, but could be publications like the Workers' Compensation Medicare Set Aside Reference Manual, or bulletins that come out from CMS on that are issued specifically to providers. Those all could be national coverage determinations. CMS is really not clear on a lot of this direction, but one thing they have made abundantly clear is they will reduce payment to Part C and D plans that they believe are not doing a good enough job enforcing the secondary payer rules. They have started doing that with respect to the group health plan Medicare secondary payer enforcement. So, you know, again, group health plan would be somebody who is Medicare eligible but is still working or is still qualified for coverage and participates in coverage under an employer-sponsored group health plan. If CMS is aware that that coverage exists, they will reduce payment to us as an incentive to us to make sure we are enforcing the secondary payer rules. We're not paying claims we shouldn't be paying primary and so forth.
Brian, I don't know the percentage of reduction at the capitated rate, but is it a set dollar amount in the group health plan sphere when there's an MSP issue, or is it a proportionate rate, or do you even know? Because I think it's a little bit of a...
I'm not involved in the group health side, so I can't speak to that. I don't think it's a fixed amount. And one of the issues that's troubling for us, though, is CMS has said they plan on doing this across the board, not just group health, but also non-group health. They haven't given us any indication yet of how this will play out for non-group health. So much like the guessing game that the non-group health players have to do with respect to what the set-aside rules might be, or some of the intricacies of Section 111 reporting. We face a similar situation. We know that rules are coming, but we don't know when, and we don't really know what they're going to be. We just keep getting warned by CMS these will be happening. Humana's approach has been, it's going to be much harder to comply if we get caught flat-footed when these rules are announced. Let's be proactive and try to anticipate what the rules are likely to be and move in that direction before the rules are announced. We probably will not be 100% right, but we feel we'll be much closer to what the rules are if we try to follow whatever CMS currently does for MSP and MSA enforcement with respect to Parts A and B. So in answer to your question, we don't really know what I can't speak to what the fee reduction is on the group health side. I think we're more in a situation with the non-group health MSP enforcement of something like liability set-asides, where you could potentially see a lot of things going very wrong because CMS may not understand how liability claims are settled, and potentially they make some assumptions about how much is recoverable from an accident based on an algorithm or a theoretical concept or whatever, and we are penalized for that. That would be one of our biggest fears.
Thanks, Brian.
So the general direction we get is we must identify primary payers. If we can identify no-fault coverage, workers' comp, or a set-aside, we should avoid paying for claims that those entities should pay for. And then coordinate benefits. So if we know that no fault has partially paid a provider for an accident, we are supposed to reduce the Medicare payment on that claim as well. And then if we can't tell, we make a conditional payment. And either we can't tell that there's a primary payer, we don't know how much they really can pay, or for some reason, primary payer won't pay promptly, which is usually going to be your liability claims or contested work comp. It might also be a contested no-fault claim. We will pay the claim and continue to investigate it. One issue that I think a lot of payers, or non-group payers, may not appreciate is that treatment providers frequently do not tell us that there's other coverage out there. It is fairly commonplace, especially for no-fault coverage, to a lesser extent work comp, but for no-fault in particular, for a provider to bill both a Medicare Advantage plan and a no-fault coverage at the same time. And then, they may issue a refund to Medicare Advantage later. Their accounting may be so bad that they may not realize they've been double paid, or they may not understand the Medicare secondary payer rules and not realize they have to make a refund to the Medicare Advantage plan. And again, that mostly happens with no fault, but it sometimes will happen with workers' comp. And in those situations, it most often is a problem for us where the provider does not complete all of the fields on a claim form that are available to them. CMS, for original Medicare, will frequently block payment if they, and is allowed to block payment in cases where they believe that there's no fault coverage indicated on a claim, but the claim isn't completely filled out. It isn't clear that Medicare Advantage plans can do the same thing. And we'll get into that in a little bit on another slide.
Brian, just a quick question. You talked about the three different, central insurance types relative to non-group health plan coverage. Do you have any anecdotal percentage breakdowns around specific recovery in the Part C realm as it relates to work comp versus no fault versus liability? Is it like way higher on the liability end and not so much on comp, or is it pretty much split evenly between the three types?
Well, we actually normally think of it differently than what how CMS would think of it. We normally will look at it by type of accident rather than coverage type. And I think this is true across most of Medicare Advantage organizations. So we will look at auto accidents as a group, slip and falls as a group, medical malpractice as a group, and work comp as a group, and various other accident types. So we don't necessarily make a distinction between no fault and liability for an auto because it's all the same accident to us. We don't care if the payment comes back from no fault or if it comes from liability, because it all ends up getting applied back to the claim and reported to CMS eventually anyway. In terms of a breakdown, when you think of it that way, the majority of activity at most Medicare Advantage plans, and I should say, in addition to doing these presentations, I'm also very active in doing presentations for other Medicare Advantage plans and to vendors that work for both us and other Medicare Advantage plans. I would say our industry sees a lot more savings and recovery off of automobile accidents than off of workers' comp. And I'm aware of the data that CMS reports to Congress, which would say the opposite. Work comp is a much bigger pool of money than auto accidents. Now, CMS, the math that they use to get to that figure is not really clear to me. But one of the things that does seem clear is CMS is anticipating that any money that goes to work comp, whether it's tied to a claim that's eventually submitted to Medicare or not, if it's set aside or work comp and they're paying for the claim, CMS feels they can count that as savings. That might be true, but we have no way of validating that off of claims that actually come in. So if a work comp carrier or if a set aside is properly administered and we never see the claims, we're not going to show that as a result. So
Gotcha.
we won't see the savings, we won't see the recoveries because the claims never came to us in the first place, which we're fine with. So one other thing, as far as those regulations, I talked about the regulations that apply across the board to Parts A, B, C, and D. One of those regulations is 41124A, and that is an automatic authorization for Medicare, in this case Medicare Advantage, to obtain any information that's needed for administering the secondary payer rules. One of the issues that we encounter is that parties involved in settlements do not want to give us information or don't want to report settlements to us. We have an automatic right to do it, which potentially can create problems for the beneficiary if push came to shove on something like this. So I just want to make people aware that this is baked into the MSP rules. Let's go on to the next slide. So specific to MSAs, there really is still not a lot that's available to that directly speaks to Medicare Advantage plans. There's actually more that speaks to prescription drug plans than Medicare Advantage, believe it or not, even though the vast majority of the claim expense is going to be on the medical side in our world, at least. But here again, we get into the discussion before about a national coverage determination could include things like the MSA reference guide. So the essential direction is, we are supposed to coordinate benefits, use and utilize the Medicare secondary payer rules along with data that CMS provides to us. We are supposed to investigate all reported set-asides, Specifically, we are supposed to contact the carrier or the MSA administrator to confirm what are the covered conditions and medications. We get diagnosis codes in the data, and I will talk more about the data that we get in a little bit, but at this point, we still don't trust, even if CMS told us to trust the diagnosis codes, we wouldn't. CMS does not pass along the actual medications that are contemplated by an MSA. That is information we have to get from other parties. CMS won't give that to us directly. There are some signs that could change. CMS also currently does not authorize us to go to the contractor that supervises the set-aside program. Ironically, Part D programs pay an annual fee in order to get access to this data that is used to fund the set-aside program, but we're not allowed to take full advantage of it. And then aside from doing the investigation, we have to make a good faith effort to actually investigate the existence of work comp or an MSA in any case where we think it could be there. And if we can determine that work comp or if work comp was available, whether it's been claimed or not, just like under regular MSP rules for original Medicare, claims really should not be processed or paid. If we make a determination that work comp or an MSA should be paying, we should not pay. Next slide.
No, Brian, just really quick while you were going through this, I was just thinking about it. So when there's a submitted work comp Medicare set aside through the WCRC, and there's been an approval of that WCMSA, there is a specific code within the beneficiary's common working file.
Yeah.
Is there any, and obviously that's for Part A, Part B, is there any type of flag where Medicare Part C or D plan is alerted to with respect to just the existence of a WCMSA that would allow you to coordinate those benefits if you believe that there are funds available and it hasn't been depleted or exhausted?
Yes and no. That's a teaser for another slide.
Perfect.
So, couple of misconceptions. So we get data from CMS, as I mentioned. But CMS does not give us the full details of the MSA. We don't get a copy of whatever is submitted to CMS. Frequently, we will ask for one from either the administrator or the carrier or the beneficiary or their attorney, whoever can give it to us. Again, we have that authorization. But CMS says really they want it to come from either the payer or the administrator. And if we can't, we make a determination based on the best information that we have. Sometimes that will be data that comes from CMS that tells us, here are the diagnosis codes that were included in the Section 111 reporting. Again, we don't get the pharmacy, the prescription drugs specifically. Beyond that, the other common misconception that we run into is somehow we have access into how much funding is available, how much was allocated to this drug or this treatment or any of that. We don't see that level of detail. We also can be aware that there's obvious mistakes in the information that CMS passes to us. Frustratingly, we are not allowed to fix those mistakes. CMS does permit us to fix mistakes if we see problems in a record for a group health plan that's primary, but nothing on the non-group health side. And we'll talk a little bit later, there is a system that allows the Part C and D plans to do that, and also used to allow the claims payment contractors to make corrections, and CMS has shut off that functionality for us. And fundamentally, the reason is they want primary payers to take responsibility for their data. We can't coach on MSA administration. If somebody is self-administering, we really can't help them. especially since we won't know we won't have any of the information, but even if we did, we really are not authorized to do that. We can't help with any of the reporting. We can't validate whether anything is properly paid out of, should it have been Medicare covered, should it have been paid out of the MSA, have you properly exhausted funds? We cannot do that. The other restriction we have, which is interesting, is a relatively new one. We can't recoup payment from pharmacies. In other situations where we know there's an MSA, we'll deny claims if we can't get recovery, or can't deny claims. We've already paid them before we found out an MSA is there. We could go to the MSA and try to get paid, or frequently it's just easier to recoup payment from a provider. We just can't do that with pharmacies now. And that's less than 18 months ago that CMS directed us on that. Next slide.
A question there, Brian, and thank you for some of those misconceptions there. And as you may or may not know, in a submitted MSA situation, CMS requires annual attestation to occur, or attestation to occur if there's been a temporary depletion or permanent exhaustion. I assume the answer is no, but Medicare Advantage plans don't receive that attestation data or information from CMS. Is that correct?
Correct. We do not get a copy of the attestation. And if one is sent directly to us, it doesn't do us any good. What we would need to see either in the data we get from CMS or on CMS letterhead, somebody gets a copy. I assume these letters exist, I just have not seen one. We would need something either in the data we get from CMS or that somebody can pass along to us that they've received from CMS, showing CMS is okay and funds are temporarily depleted, or funds fully depleted and CMS is okay with that. Eventually, it should show up in the data, but I wouldn't rely just on the data alone.
Gotcha, thank you. And hopefully it's something that can be remediated because CMS, as you know, has rolled out electronic attestation submission. So I imagine that would be easier to pass along that data should CMS decide to do so versus having a paper form of the information. Yeah,
it hopefully that speeds up the process so things would at least show up in the data we get from CMS sooner, rather than CMS having to get a hard copy and then upload it and have a contractor update systems. Hopefully that just automates that whole process so it shows up in the data sooner. Otherwise, if the data from CMS says there's still money in the MSA, that's what we really have to go off of.
Gotcha.
Something that I haven't heard discussed a lot that I wanted to talk about, though, was the direction that CMS is giving to providers. I thought for MSA discussion, it's really useful. So think of the MSA reference guide, and I'm going to get these numbers wrong, but to me, I want to say that's like a 100-page document that's issued to the parties that's given to parties that are contemplating negotiating a set-aside. Then there's the self-administration guide, which I believe is about 50 pages. The specific direction to Medicare Advantage plans and Part D plans could all be put into a single 10-page or less document. We have to jump over to the reference guide or other bulletins that CMS has produced to fill in the gaps on that. We can do it, though. Providers get even less. So the only document that I'm aware of is this bulletin that came out actually in 2017, was updated a few months ago, with direction to providers about accepting payment from patients who are self-administering set-asides. The July update is particularly interesting because that's the first time since this publication was given to providers as a bulletin for the providers that log into the education system that CMS has set up for them. the first time after 2 years of issuing this bulletin and updating it periodically, CMS finally said, oh, by the way, if you're curious what an MSA actually is, here's a link to the reference guide that is given to the settling parties. So the providers really have nothing. That document doesn't tell them explicitly you need to identify MSAs. It doesn't give them direction on how much they can charge when an MSA is available. It only basically says if somebody tells you an MSA is around, it's okay to bill them if they say they self-administer. So there's a lot of opportunity here, unfortunately, for providers who don't know anything about the MSA program to get things wrong and to potentially get into conflict with the beneficiaries, especially if they're self-administering.
I agree with that. Just some color around that. We work very closely with providers to educate them on CMS's requirements around WCMSA administration. A lot of effort goes into purely just provider education so they understand it. To your point around this slide, and I think it's a really important slide, you know, a provider gets someone with a WCMSA if they just think it's a self-pay situation when it really is not, obviously based upon this slide, so thank you.
So now let's really dive into how we actually enforce the MSP rules. And I would say Humana is not that different from most of our competitors. It's sort of a model that everybody kind of falls to. People do it different ways depending on if they're like Humana and they perform most of the work in-house versus outsourcing to vendors. But the model mostly is the same. We're going to look at claims as they come in the door and look for things like diagnosis codes that indicate traffic accident, or more importantly, codes that indicate there's another payer on the claim. Because again, if we don't know that there is going to be coverage out there, knowing that something's a car accident doesn't necessarily help us. Statistically, I believe the last time I saw numbers, better than 90% of the time when there is a traumatic injury reported through the diagnosis codes on a claim, the cause of the injury is not reported, even though there are abundant cause codes available through ICD-10. And that predates ICD-10. You know, ICD-9, there were codes available, maybe not as many. Those codes just weren't used. So frequently what happens is those trauma codes may be paid because there's no way to identify a primary payer, and we continue to investigate the claim either through questionnaires that go out to the beneficiary, in some cases matching to traffic accident reports. We've had a vendor that did some work on identifying lawsuits, personal injury lawsuits. And I know vendors, and this is something we're seriously considering, is getting access to data in multiple states. Like, for example, in Texas, we can give data to Texas. Texas will report, the state of Texas will report work comp claims to us, but other states are making that available, and there are vendors that specialize in that. And then really, in our world, the data that I'm about to get into in a lot more depth is something that's used as a second sweep to see if we've missed anything. We do some upfront work with it, but mostly we're, for a variety of reasons, the method that we have largely works. It's not perfect, but we can find a lot of opportunity through prepayment screening and through post-payment. We may not always identify who the payer is, but then as part of our process, once we've identified the opportunity, we and really most Medicare Advantage plans are going to try to notify everybody involved right away. Unfortunately, sometimes that is going to be after a claim has settled, but CMS has made very clear, and courts are tending that way as well, that notification is, the timing of the notification is not necessarily that important. and I know there are entities out there that really are less aggressive and less proactive about notifying than we try to be, but the principle is find out who is involved as a primary payer as soon as you can and get them on notice, ideally before a contested claim is settled, or liability, or no faults exhausted or whatever, early on. We also want to alert the payers as well as providers and the attorneys involved if there's a plaintiff attorney. Our process really is not that different from what CMS would do in terms of sending conditional payment letters and demand letters. We call those letters something else, but really it's get everybody a notice with an itemization of how much we've paid as soon as we can, and then send a demand, particularly after settlement if we're not promptly repaid. Next slide. How we will actually recover those conditional payments, I've touched on this already, especially with something like no fault or workers' comp. We may seek payment directly from the payer, but a lot of times we will actually, it functionally is easier to just go to a provider and say, you billed us, you should have billed workers' comp. Especially in a case where we're having difficulty dealing with the workers' comp carrier. If it's easier for us to go to a provider and say, you need to bill the work comp carrier, and we want to make sure you know who that work comp carrier is, we'll pass the information on to the provider and tell them to bill work comp. Nothing really requires plans to do this, and there are an awful lot that will just bill work comp. And then, especially on liability, we'll recover from the settlement funds or directly from the carrier at the time of settlement. As a last resort for us, we do file litigation. I'm sure everybody's heard of Humana cases. We are very careful to pick the cases we go after. We try to provide everybody with opportunity to avoid a lawsuit before we actually file. So again, we're sending out notices beforehand. We're giving people an opportunity to contest, especially the beneficiary. They have a right to appeal a Medicare secondary payer determination. It doesn't matter if it's Medicare Advantage or Original Medicare. They have the same appeal rights. Beyond a couple of internal appeal steps, it's the same process. Once it leaves our house, it goes to CMS for their regular appeal process for secondary payer. So we're going to make that available to somebody before we actually file suit. We're going to give everybody notice, and if we can't come to a conclusion, that's when we file suit. Frequently what we see on lawsuits is that the parties that we're working with, especially the payers, will start to say, hey, we have a settlement agreement with the attorney and the beneficiary. Give us time to get them to honor their commitment on the settlement agreement, and we're happy to do that as long as we have the time to do it. So again, litigation is the last resort. So let's dig into the data now. So everybody knows about the common working file. Maybe you don't know the details of it. The common working file is built off of Section 111 data, as well as data that's collected from other sources available to CMS, such as investigations that contractors will do off of claims they receive from treatment providers, data that's poured into the common working file from the work comp contractor, self-reporting from beneficiaries and their attorneys, and so forth. They send a monthly file to Medicare Advantage plans that has some of that data. Not the full common working file, but a reasonable subset. They send even more data on a daily basis, or effectively it's daily. It's, the timing might be a little strange, but it's much more frequent than monthly, put it that way. That goes to the Part D plans. There's also a system that's available to the Part D plans. I touched on this a little bit before. It's called the ECHR system. It's a restricted access portal where we can communicate with CMS on particular, in particular for group health coverage. We are no longer allowed to do that for non-group health or anything with set-asides. It's the same system that claim payment contractors for CMS will use to communicate with CMS, where they may report an opportunity for Medicare secondary payer enforcement through whatever they're doing on prepayment screening. So it's limited feedback. It's really not useful for identifying when there's other coverage available. It's just not built that way. So we rely on our own methods that I talked about or the data we eventually get from CMS. The providers on the get a completely different system called the HIPAA Eligibility Transaction System, or HETS. It's restricted to treatment providers. There is some indication that people can get cooperation from a treatment provider to get into that system. And it does have some limited MSP data, but it's really built for providers to know, is somebody eligible for Medicare benefits? Is there an indication that there's primary coverage that they should be asking about? And a lot of the information in that system is really geared towards things like benefit counters. So like, have they hit their annual limit for X benefit under Medicare? Really what the system's built for. It's not really built for MSP enforcement, but it does include some MSP data. So let's get into now let's start with the Medicare Advantage monthly file. A lot has changed, especially over the last year and a half on this file. The file structure hasn't changed. So those labeled columns in terms of who the primary payer is, the injury diagnosis codes, the source of the data, all of that hasn't really changed that much. The structure of these files hasn't changed. What has changed is about a year and a half ago, CMS completely revamped the guidebook that they send out to plans. We already had some indications that there was better data in there. So for example, we've known that date of injury seemed to appear and plaintiff attorney information and so forth. But it's none of that's labeled. It's all very hidden in the file. You can find it if you know where to look for it, and it became much easier to look for it when we got the revamped data guide from CMS. If I was paranoid, and I tend to be on these things, that to me is a first step signaling that CMS is getting ready to make sure we're using the data as they've told us we have to use it. One of the new things that showed up in that data, or maybe it was there sooner, but we couldn't find it without better direction, was the existence of a set-aside. That really started showing up, and we don't get a lot of detail on the set-aside. Basically, the administrator is identified to us, and the diagnosis codes that should be covered by the set-aside, but not a whole lot more than that. But there are also things that we've noticed are, we'll call them breadcrumbs, so these MSAs that are reported are going to be the submitted MSAs. You can derive from the data some obvious examples where there's a non-submitted MSA or alternative arrangement, if you will. And that's something that we started to explore. The next slide, please. So the Part D plans, as I said, get much more data. So we will get the approval status of the MSA, for example. And again, this is data that's been around for quite a while. Our understanding of it and the understanding of other plans probably got better because CMS a year and a half ago published updated guidance on how to use this data. So we know the approval status. Was it submitted? Was it rejected? Was it approved? And so forth. And variations on that, the administrator and also the dollars that are allocated to pharmacy. We'll also know, is there still acceptance of ongoing responsibility for medicals? If there isn't, when was that shut off? and so forth, with respect to the primary payer themselves, specifically. The dollar amounts, though, that in terms of what's allocated to pharmacies or how much of an MSA is allocated to pharmaceuticals, that's less relevant to us because, again, it really doesn't matter to us how much the settlement is in terms of how much is allocated to an MSA. It's really more important to us to know which drugs are actually contemplated or which treatment is what treatment's contemplated. There's also, basically, in an ideal world, the Part C plans would get the same information that the Part D plans do. We don't. There are a lot of mistakes in these files still. I should mention, I talked about the guidance being better from CMS in the last 18 months. The other thing, because we've been working with this data now off and on, I've been involved again, back since we set up our original Part D program. This data is notoriously bad in terms of consistency, but we've been able to figure out where a lot of the problems are. Self-reporting is bad. Section 111, by and large, is pretty good. If you can tell that that's where the record came from, it's fairly reliable. The diagnosis codes I still wouldn't rely on. I think a lot of people that are doing Section 111 reporting miss an opportunity on the diagnosis code reporting that they'll have to address eventually. But at least who the carrier is and that sort of thing is still it has gotten much better than what we used to get from CMS. Where we run into problems on both the Part C and D data tends to be more with the conflicts between what responsible reporting entities submit and what comes in from providers or from self-reporting. We're definitely able to make better use of this data than we could 2 years ago, and there are a lot of opportunities for us to get even better with it. On this next slide, I want to talk about, I talked about the HET system. Here's what the providers actually see. It's a massive file. A lot of them don't actually get it directly from CMS. They may go to contractors. They'll get the patient information that they put in. They'll be told what type of insurance coverage might be primary. But there's no clear indicator that tells them there's an MSA out there. They'll get carrier name. Based on what we see in the data we get from CMS, they may get, if an MSA is out there, they may be told instead of a carrier name, they might be given, say, the beneficiary's name, which most providers are going to assume is a mistake in the data. If they see something like that, they'll see, coverage effective date, which could be an accident date. They'll see the exhaust date. Within the last year, CMS has indicated they will provide diagnosis codes. I don't have direct access to this data, so I'm only going off of the direction CMS is giving to providers. But I don't know if the diagnosis codes appear on all of these records or on some records. I just know that the announcement was made, the data is going to be populated in this system when it's, in some cases. But it's really not a lot to go on. There's nothing that's going to flag a provider to look for an MSA, in my opinion. Especially with the direction that providers are given elsewhere for MSAs.
Brian, one question that we got that came through the chat box, and one that I actually had too, so we can kill two birds with one stone. I think there's a misconception that Part C plans receive the entire Section 111 file with every single data point. Can you either confirm?
We do not.
Okay.
Nope, we do not. Maybe half of the data points. The other thing is that, I talked about this in terms of monthly files versus daily files and so forth. There's an awful lot of lag in the system between when a report is made through Section 111 and when the Part C and D plans actually get it. So we may know when CMS got the data. When we see the data, it could be 30, 45 days later. we're not seeing everything anyway. I am familiar with the general outline of what is put into Section 111. I would love to get that data. If we could get CMS to pass that along to us, or better yet, in some cases, there are carriers that we're in discussions with or we have commitments from to start getting some of that Section 111 data from primary payers, I think we could do a lot better on avoiding payment where we don't need to make payment. But CMS isn't giving us that data, unfortunately.
Gotcha, thank you.
Some of this last section is really about, level setting on what the beneficiary's obligations are and what some of the obligations of other people would be in this system. Really, it's a beneficiary's obligation, and this is, whether they're self-administering or not, they are supposed to make sure that no-fault at work comp pay for claims so that Medicare or Medicare Advantage doesn't have to. They also have an obligation to reimburse conditional Medicare payments if they receive payment, and cooperate with MSP investigations. I don't think any of this is necessarily controversial. There is a risk when they don't do this that they could trigger a claim denial. CMS has made clear that Part D coverage is not a guaranteed benefit. You can be terminated from the Part D program, not only losing coverage for the drugs that a MSA should be covering, but for any other conditions you might be treating for. For example, diabetes or a heart condition or something like that. The only thing right now that's preventing that from being widely implemented is CMS has removed the chapter in the guidance to the Part D plans that covers benefit termination. It's not something that, honestly, Part D plans don't want to go around terminating coverage. But at some point, CMS is going to put that chapter back in play with clear direction on when they expect us to petition to have CMS terminate the coverage. And it's just a matter if there's somebody who's under original Medicare and a beneficiary is not paying conditional payments back after settlement of a liability or a contested work comp claim, they could lose not only basically tax refunds, Medicare benefit, not Medicare, but Social Security income. That's all. CMS regularly does that. Potentially also, with respect to a Part C plan that would deny coverage because of MSP enforcement, you could also have providers who, again, don't really understand some aspects of the MSP rules pursuing their own collection activity against a beneficiary or a patient. There's also a risk, especially with self-administered MSAs. There's no direction on this yet from CMS, but it's something that I would watch for, which is coordination of care transparency. So CMS is giving us direction to the Part D plans in particular on watching for opioid abuse. But there are other situations where an MSA may cover medications that really would be contraindicated or would potentially have side effects that other medications, coming into play for those, pre-existing condition. Maybe the medication that's being prescribed for a diabetes or heart problem or whatever, that shouldn't be mixed with whatever's being contemplated under the MSA. So in terms of a care coordination issue, there's probably a risk out there that if an MSA, particularly if it's self-administered, or if you have a professional administrator that's not watching what's going on with respect to Medicare Advantage, you could have people put in harm's way because the two sides are not talking, or the self-administered beneficiary doesn't know that this is an issue they should even be worried about. Part D plans put an awful lot of effort, and Part C plans put an awful lot of effort into preventing harm in these situations. And by us not having a window into what's going on in the MSA, our efforts to prevent that kind of harm really are hampered. The next slide, please.
I think just a quick note there too, I think you're exactly right, and that was the reason CMS put in their most recent guidelines in the WCMSA reference guide that a competent administrator needed to ensure adherence to Part D drug utilization, as well as incorporate drug management programs when there are frequently abused drugs. They gave us our first use case where they highly recommended, not only just in general, but highly recommended for specific utilization of professional administration when frequently abused drugs are indicated in a particular MSA. So that's a good point.
Yeah, and now on the Part D side and Part C side, we've always been watching for opioid abuse, partly because, not necessarily in terms of the coordination of care angle, but it's a frequent hot spot for fraud, waste, and abuse. You might have somebody who is doctor shopping to get an opioid prescription, at which we're trying to protect that person from themselves in a lot of cases, but also that's a sign that there might be some shady behavior from a prescribing physician or something like that. And we want to make sure that we're on top of that, because in addition to our Medicare secondary payer requirements that CMS expects us to enforce, we also have to enforce the Medicare payment integrity rules too. And so it's something we've been watching for quite a while, but the tea leaves are there. CMS has put additional direction out to the Part D plans specifically around opioids, and specifically geared not just on fraud, waste, and abuse, but also addiction prevention. So it's going to be an area to watch. Patients, on this next slide, patients are not, and beneficiaries are not the only people that are at risk. There's an obligation on the primary plans to make sure Medicare payments, conditional payments, are reimbursed. And there's an obligation to provide information to CMS at a minimum, but arguably also the Part C plans because of the regulations that are extended to us. Some of those risks are going to be interest charges, and I think most people on this call are aware of the private cause of action. I'm not going to spend a lot of time on it, but I will say that, to my knowledge, there's not a court out there that has considered the private cause of action issue and not sided with the Medicare Advantage plans on it. Again, we are not going out of our way to file litigation, and some of you may be aware, the original impetus for pursuing the private cause of action was that CMS says we are going to reduce payment to the Medicare Advantage plans that don't enforce the secondary payer rules. But they weren't giving us any support to enforce those rules, just the obligation to do it. Humana eventually decided either the courts are going to say that what CMS is telling us is accurate and we can do what CMS expects us to do, or the courts are going to tell CMS they're wrong. So we will have to basically force this issue by going into court. That's really where all of this started, was to clarify what those obligations were. Since Avandia, I've been involved in selecting and screening all of the files that have eventually gone to litigation on this. And that's where we're coming from on the private cause of action issue. It's really not about making profit off of double damages, because you have to figure out how to report all that money back to CMS anyway, which is sometimes not worth it. It's really about demonstrating compliance with CMS or clarifying what the rules are in cases where we don't have clear guidance from CMS, and finding out what the courts will allow us to do if CMS forces us to do something. One other point on this slide is, the payers and the claimant attorneys also are probably going to have some obligations to the beneficiary. So if claims are denied because of the settlement wasn't well set up, or the MSA wasn't properly self-administered, or something like that, there's some risk that somebody's going to be coming back to the primary payer or to the attorney that helped get the process going. How big that risk actually is, I can't say. But I think as you see CMS enforcing the MSP requirements and MSA requirements and making a concerted effort to force the Part C and D plans to do that, I think that risk increases. Whether or not it's a legitimate risk and there's a real harm there, I don't know. I just think it's an issue for other people to watch. Or next slide. Some suggested best practices. Really, Humana won't take a position, and just as CMS won't take a position on when is professional administration proper. But personally, again, not speaking for Humana, I don't know of too many situations where if I was in the beneficiary shoes, knowing what I know, I would probably want to go with professional administration. But again, that's just me. I think the risks are very high of something going wrong. I would not want to be dealing with providers who don't understand these rules. I don't have the patience for that. And I don't have, if you're a self-administrator, you really don't have any leverage against a provider that I can see. So now there are people that are perfectly well suited to self-administer, so maybe they're fine, but I think 90% self-administration just is unbelievable, and that's something that people really need to consider. Aside from the MSA discussion, identify all of the Medicare payers that are out there before settlement. Get those cards that show, is it original Medicare, is it a Humana Medicare Advantage plan? Find all that out. Again, you're not going to get an official position from Humana. Me personally, I know the PAID Act proposals out there to try to get CMS to release information about Medicare Advantage plans to the primary payers at the time of settlement. Overall, I think that's a good idea. I think there's some room for improvement on it. I don't think the look-back period's far enough back in particular, but I think it's better than what we have right now. But in the meantime, the payers really, especially, but plaintiff attorneys as well, need to find out who is paying for the medical care while a disputed case is going on, or who might have been paying, even if it's a work comp case. As I've said, providers frequently will bill both work comp or no fault and a Medicare Advantage plan. Getting ahead of that before it becomes an issue is really valuable. Contact the plan once you've identified them before settlement, check for the conditional payments, report the diagnosis codes and the pharmacy coverage that the MSA should be taking care of. Frequently, Humana will ask for a copy of the MSA. Again, CMS doesn't give that to us. And I understand there might be situations where people are not comfortable giving that full document to us, but at least give us the diagnosis codes and the medications, rather than forcing us to rely on the diagnosis codes that might not be totally correct in the data that CMS gives us. And some of the, or to make a determination based on the best information we have. Ultimately we will get the information. It's just a question of, how many hoops do we have to force other people to go through before we get it? And also, if you're settling and you've picked a professional administrator, give that information to the Medicare Advantage plan so they can start a conversation as well. And if an Advantage plan shows up post-settlement and an MSA is in place or some similar arrangement, share as much of that information as you can with the Part C plan as well. And also any documents, we talked about this before with the data that CMS gives about exhaustion of the MSA or temporary exhaustion for something that's annually funded. We don't get any of that information from CMS except for through the data that they pass on to us. The Part C plans only know, is there an MSA, yes or no? We don't know much detail beyond that other than the administrator or the diagnosis code. We can't tell you. If there's a record in the data we see, we're assuming there's funding, unless we see something on CMS letterhead that says we're satisfied you've exhausted funds. And I think that's it. I guess one other thing that we really should cover, Sean and I had talked about before the presentation, was some of the direction that could be coming down the road. So things that we probably should be watching for are, when the Section 111 regulations finally are updated, and I know they've been delayed yet again to probably the end of the year, that probably is going to be a precursor for better direction from CMS to the Part D and Part C plans about how they expect us to use the data we get. CMS has been very clear that they think Section 111 is better than self-reporting. When they start enforcing those rules and start doing the civil monetary penalties, I would place bets on CMS coming out with new direction to the Part C and D plans about how they expect us to use the data, possibly also improving the data guides that they give us. When assuming regulations come out on MSAs, now I know that's been pushed back again, there probably will be some more direction to the Part C and D plans about how MSAs should be enforced. And if it doesn't, even where those regulations are put in place, if they're put in with the regulations for, say, work comp MSP rules, that's going to tell the Part C and D plans a lot about how we should be enforcing things that we don't already know. We do expect audits from CMS on our MSP enforcement at some point. To a certain extent, those have already started. Not a focused audit that only looks at MSP. Really, CMS's focus on the focused audits right now is claim payment accuracy, which sometimes picks up MSP issues, and grievance and appeal issues, and things like the provider directories that we issue to members. When they are satisfied that those issues are taken care of, I think MSP is on the table as a focused audit that we will have to watch for. And I would also watch for really what, Humana, humble bragging here, we are on cutting edge in some respects, if not a lot of respects, for how MSP gets enforced. We're starting to see, I think there are Part D plans that have always sort of gotten it in terms of enforcing MSP, and they send out letters and they do their investigations. I think you're starting to see a shift in awareness on the Part C plans. So you could see more activity there. And there's been a lot of litigation that's coming from entities that are tangentially connected to Part C plans, but I think you could still see other Part C plans, especially if CMS starts auditing or threatening audits. You're going to see more activity from Part C plans than you might right now, outside of Humana and a few others.
Thank you so much, Brian. Appreciate it. I know we went over, but I want to thank all of our attendees and especially you, Brian, for providing this really enlightening, helpful educational material. And I know you told me beforehand that I could provide, we don't have your contact information here, but you said I could provide your email. I just want to double check, make sure that's okay before I do so.
Absolutely.
Okay, it's bbargender, so BBARGENDER at Humana, HUMANA.com. Again, it's BBARGENDER at Humana.com. With that, we're going to let you go for now. We appreciate you joining this Ametros webinar, and really thank you so much, Brian, for your time today. Appreciate it very much. Thank you.
Yeah. Yeah, feel free to reach out to me if you have questions that I couldn't get to today, or if you want to talk about specific Humana members and you haven't gotten a letter from us already, feel free to reach out to me. I will get you in contact with the right people.
Thank you. Goodbye.
Take care.